I'm Paul Goss. Good morning, and I want to welcome everybody, all viewers and participants on camera, to our Global Breast Cancer Tumor Board this morning. Today we are doing something slightly different, and we have a special session on genetic profiling for metastatic breast cancer, basically as a paradigm for genetic testing of all solid tumor malignancies. We have two very special guest presenters who are each going to use an example of a case scenario of a patient with metastatic breast cancer as an introduction to their laboratory studies, acting as clinical management tools. Dr. Ben Parker is a distinguished physician, scientist, and professor at Johns Hopkins University. Dr. Parker translates laboratory genetic studies into diagnostic and therapeutic studies in breast cancer. And Dr. Aditya Bardia is a distinguished medical oncologist and assistant professor at MGH Harvard Medical School, whose interest is in developing targeted therapies and is a leader in understanding the significance of circulating tumor cells. As usual, this morning's session will be recorded and archived and will be available to our colleagues online and those related to you in your groups for subsequent viewing at any time. At the end of today's presentation, please take 5 minutes to take a photo of your group or yourselves and send this after the meeting to Jessica. We'd appreciate that. And with that brief introduction, Ben, I'd like to introduce Dr. Ben Parker as our first speaker of this morning. Ben, over to you.
Thanks very much. Jessica, will you advance the slides for me when I say to? Is that okay?
Sure, yeah, that's great.
Okay, great. So good morning, everyone, and welcome. This is a little bit different, and again, most of this is still, at least in the United States, for research purposes, and particularly here at Johns Hopkins. But there have been a growing number of institutions as well as commercial entities who have been offering sequencing of a patient's tumor. And so, like many institutions, people are coming to us with the results of these tests. And many times what we've been seeing is that there's a lot on there. Some of it is very difficult to interpret for a lot of oncologists, particularly those in the community that might not have actually had a thorough understanding or background of some of the molecular biology and genetics that accompanies these reports. So the purpose really of what we have created about 3.5 to 4 years ago now at Johns Hopkins is a personalized kind of medicine effort where we really want to take a patient's tumor, sequence it, but then importantly also incorporate a molecular profiling tumor board to help interpret all of these genetic alterations and then to refer that back to the physician as well as the patient. We have dubbed our particular tumor board something called the Genomic Alterations in Tumors with Actionable Yields, or Gateway Tumor Board. Excuse me one second. And the Gateway Tumor Board was really formed in response to the need of having the interpretation part. Again, there are a lot of companies as well as institutions that are doing the sequencing, but there's kind of been a lack heretofore of the ability to take all of this and say, well, what would really be in the best interest of the patient and physician? Next slide, please. And so our mission is, one, to review the patient's molecular tumor profile, really from any source or platform. So we've reviewed things from other institutions as well as multiple different companies and different platforms within those companies, blood versus tumor, etc. We really rely upon our panel to review the relevant literature. What is the evidence at this moment of time that such genetic alterations really are of functional significance, and could they really be actionable? We also try to review the current state of the FDA-approved therapies that are right now in the United States, approved not necessarily for the cancer in question, but at least approved for some sort of indication or some sort of cancer. We also look at the clinical trials that would potentially match up with the individual genetic alterations in a patient's tumor profile report. And then we really debate and want to get to the evaluation of what is the weight of evidence for current standard of care versus things that look potentially actionable on the patient's report, and what would likely be in the best interest of the patient in terms of responses to therapies. And finally, we want to discuss and prioritize recommendations based upon all of the above information, the genetic assays, but as well as where the patient is with their disease. And in particular for breast cancer, as I'll mention later, that this can be somewhat challenging because we have so many options. But then ultimately we will convey the Gateway Tumor Board suggestions and recommendations back to the referring physician and patient. Next slide, please. So if you look across the literature, if you look across different reports, actionable really is defined in different terms. We have come up with 4 bullet points here, and again, this is not necessarily set in stone and can be a moving target. It's very dynamic as our field progresses forward. But minimally, this is what we've come up with. Number one, a genetic alteration that has an FDA-approved therapy for the actual given tumor type. This would really be of highest priority. An example of this would be a targeted therapy called vemurafenib. This is a small kinase inhibitor that actually targets just the V600 mutations in certain types of tumors, but approved for metastatic melanoma currently. The second one would be a genetic alteration that has an FDA-approved therapy, but is actually found in a different tumor type. So, for example, the aforementioned vemurafenib, these V600 mutations can be found in other types of cancers, and there is some evidence that in other types of cancers, though not all, these classes of drugs, these mutant-specific BRAF inhibitors, may actually afford some benefit for those patients. There was a recent New England Journal of Medicine report out of Memorial Sloan Kettering, which actually showed combinations of different therapies, including as the main staple, V600 BRAF mutation inhibitors do seem to work again in other cancers that have V600 BRAF mutations, but notably not so much in colorectal cancer. So again, these are the types of reports and science and research that we try to glean in our tumor board to make the best decisions at the state of the moment. Thirdly, a genetic alteration that may provide rationale for participation in a clinical trial of a targeted therapy. This is, again, fairly obvious. If we have something like a PIK3CA mutation, which is a mutation in the PI3 kinase gene, then it might make sense in the absence of approved inhibitors, which we currently don't have, that we would refer that patient to a PI3 kinase inhibitor trial. And the last one is something that we kind of came up with, which is becoming more adopted by a lot of centers doing this type of sequencing. And in all honesty, is probably the number one thing that we find in a lot of these reports, and that is in the right clinical context, age, family history, etc., do we find a mutation that might actually lead us to refer to genetic counseling and get possible germline testing? One of the things that we should make note of is that germline testing really means the mutation is in the DNA of that individual and can therefore be a predisposing mutation for developing cancer, and importantly can be passed along to the offspring of that particular patient. Next slide, please.
Coming, sir.
All right, so what are the additional considerations? Well, one of the things that we really wanted to think about before even pursuing this tumor board was the fact that there are certain diseases like breast cancer, as I mentioned earlier, that have a number of standard of care therapies. And what is the consideration for pursuing second-line therapy where we have good drugs versus a off-label use of a targeted therapy that we don't, as of yet, have proven value? So these are some of the issues that come up during our tumor board. We're also discovering and interpreting potential germline variants, as I said earlier, and that's something where, depending on the institution and the company, some companies will concurrently do germline testing with the tumor and then filter out everything that's germline, and so you will only get the mutations that are present in the tumor. This has advantages because then you can really focus on the tumor, but it potentially has disadvantages because you may be missing, for example, someone with a BRCA1 or BRCA2 mutation if it gets filtered out, and that individual, for whatever reason, did not receive appropriate genetic counseling and testing. And then finally, legal implications. We're really trying to think ahead about what could we get involved with in terms of legal ethical considerations. There was a case at Michigan that was reported in the New York Times, somewhat colloquially, that they actually found in a patient's cancer HIV proviral DNA, which means that patient had an infection of HIV, and yet that wasn't known to the patient, or it wasn't. If it wasn't actually put out in the report. And so these are all ethical considerations of what do we do and what is our responsibility as a tumor board to actually act upon those types of incidental findings. Next slide, please. So this brings me to the first case, and again, for brevity and for hopefully some questions and discussion, Dr. Barja and I decided that I would do one case and he would do the next case. And so this was our kind of example of a case that we've actually had, which led us to something that could be considered actionable. And so this is a 63-year-old female with breast cancer. She had, in 2009, left-sided triple-negative DCIS. This was treated standard of care with lumpectomy and radiation therapy. Unfortunately, in October of 2012, she had inflammatory changes in the left breast, and this was biopsied and was positive for triple-negative breast cancer. She actually began neoadjuvant chemotherapy in the form of TAC, and then she had an initial response, but then progression. In February of 2013, she underwent left mastectomy. There was extensive disease with positive margins. She was node negative. There was at the time no clear evidence of metastatic disease. However, in early 2013, she actually did have evidence of disease progression. It was in the lymph nodes as well as both axilla, her skin, and a growing left supraclavicular lymph node, and she was started on capecitabine. She then had second-line therapy after progression with eribulin in October of 2013. And then early 2014, she actually had disease progression in the chest wall. A PET-CT staging scan at the time showed new hypermetabolic lymph nodes in the bilateral axilla, again, disease in the left medial and lateral supraclavicular lymph nodes, multiple new nodules, and hypermetabolic areas in the left chest wall. She also had an area in the left lower paraspinal region and development of disease involving both hyla as well as left AP window lymph node. So her disease was really starting to take off at this point. She really didn't have any notable family history of breast, ovarian, or other cancers. Next slide, please. And so this was sent off for a commercial testing. This particular commercial entity actually only does tumor sequencing, so this is one of the areas where germline filtering, that is that the patient's normal DNA is not compared against the tumor. So you would get both germline and tumor-specific mutations in these types of reports. And notably, she had within the tumor an amplification of MAP2K1. She also had cyclin E amplification, MCL1 amplification, MYC amplification, and then she had 2 separate P53 mutations. Next slide, please. So our reports usually go through every single genetic alteration. We kind of, again, write in a report the pros and cons of, is this targetable, is this not targetable, would this be appropriate for clinical trial or not. I'm going to just, in the interest of time, not do that with every single mutation or alteration found in this particular patient's tumor, but I'm going to focus on the MAP2K1, which is the kind of international standardized name for a gene or a protein more commonly known as MEK1. And so this is really not known whether amplification of this gene would lead to a functional consequence, but what we know from this particular protein, where it lies in a very critical pathway in cancer, is called the MAPK pathway or MAP kinase pathway. It would be reasonable to presume that this is the case. We know, for example, in the breast cancer world that HER2 amplification leads to hyperconstitutive activation of that patient's pathways that leads to the growth of those tumors. And so MAPK can be kind of construed as a little bit further down in that pathway, where one has activation of this growth-promoting protein and therefore the growth-promoting pathway. This was important and intriguing to us because at the time a drug was recently FDA approved, which was a MEK inhibitor. This is a drug called trametinib, and it was actually approved in combination with one of these V600 mutant BRAF inhibitors, and in the combination with a particular drug called dabrafenib. This combination has now been shown to be superior than just using a V600 mutant inhibitor alone for various reasons which I won't go into. But again, this combination, and only in this combination, is approved, and again, only in melanoma. It's currently being studied in clinical trials in solid tumors. However, there was reasonable evidence to consider pursuing a phase 1 clinical trial, and the clinicaltrials.gov number is listed there, targeting MEK and AKT. Next slide, please. So we really debated and kind of thought about, well, what made sense for this patient? She had had 2 lines of chemotherapy. She still could get next line standard of chemotherapy, and at the end of the day, we actually thought that that was a reasonable consideration, considering there was really at the time no evidence that targeting MEK amplification would actually have benefit with the MEK inhibitor trametinib. We also thought that the clinical trials, as mentioned in the previous slide, was reasonable to target this with a MEK inhibitor, but again, under the kind of umbrella of a clinical trial. But thirdly, we said if for whatever reason this patient just did not want further chemotherapy, couldn't take further chemotherapy because of toxicities, and could not actually participate in a trial for whatever reason, and that's actually very common because logistically many times the trials are very far away and the patients can't travel. We said that off-label use of trametinib would actually be a reasonable option for this patient. Next slide, please. So on follow-up, what we actually found was that the referring physician, did in fact pursue and obtain off-label use of trametinib for this patient, and again, based upon our report as well as the genetic report that was sent off earlier. And the follow-up that we got from the referring physician is that after 2 weeks of therapy, the patient actually had a fairly dramatic clinical response in the chest wall. However, this was not long-lived. I found out a little bit later. After several weeks, the tumor did start progressing again. But this was really our first kind of case that highlighted that we could get a drug, pursue off-label use, and actually have a patient respond. Again, this is an N of 1, which most of these tumor reports are, and it's not something that I'm advocating. If someone has this, they should definitely get a MEK inhibitor. I'm trying to really show as an example that occasionally we do actually find something, and there is a drug that's FDA approved for a different tumor type. And again, this is also something where we don't know for sure whether MEK amplification is actually always going to lead to any type of response, and again, the caveat that the response was short-lived. That said, this is kind of how we envision our tumor board is going to operate and function. Without this type of kind of detailed discussion, it's very difficult, I think, for most clinicians to get one of these reports and think about what should I do, what should I not do. I would also add that the majority of times where we've discussed these genetic reports, we haven't really found a lot of these types of actionable mutations. This is really, I think, for breast cancer, the exception to the rule. Most of the times we will find something that makes sense or provides a rationale scientifically to pursue a clinical trial. But as I said earlier, right now the bottleneck seems to be trying to find a local option, meaning that can the patient actually travel for a clinical trial, or is there one available locally for that patient based upon the genetic profile of the tumor? Next slide, please. So in conclusion, we've had our Gateway Tumor Board operational. In fact, we meet at 11 o'clock on Mondays, and I actually have felt that this really adds tremendous value to our personalized medicine effort for cancer genome sequencing. Really, this is something that is necessary because there is just a wealth of information out there, and I think it is very, very difficult for most clinicians to really figure out or to really pull together world's experts in various different diseases, in various different expertise, not just scientific, but even things, for example, like I said earlier, the legal representation, the ethical considerations. We have a clinical geneticist on our tumor board as well as a patient advocate. And I think having a broad membership really benefits us because it really allows us to have input from all sides. We're going to continue to follow up with physicians and patients to determine if recommendations were followed, and if so, what the outcomes were, and if not, why not, and also what the outcomes were. And I think that is my last slide.
Ben, thank you very much. Before I introduce Aditya again, would you two mind if we took questions and discussions afterwards, just in the interest of time? Can we go on to Aditya's presentation, then come back to you, Ben, and have people just hold their questions for you?
Absolutely.
Thank you very much. Okay, so with that, I'd like to introduce Aditya, and we do part 2 of the B part of our presentation this morning. Please, Aditya. There we go. Let me give you the chair here. Thank you very much. Thank you, Ben.
Thank you, Dr. Goss. I'll build on what Dr. Park mentioned. I will talk about a case of ER-positive breast cancer and talk about the various clinical decision-making points as we think about molecular alterations. So start with the first slide with this patient. So this is a patient I had seen last year for a second opinion regarding management of metastatic breast cancer. This patient had her breast cancer diagnosed in 2000. In 2000, she was diagnosed with ER-positive breast cancer, received surgery, was started on tamoxifen as she was perimenopausal at that time. After 2 years, she discontinued tamoxifen because of adverse effects. A year later, she had a pleural biopsy for evaluation of shortness of breath and pleural effusion, which revealed presence of ER-positive, HER2-negative breast cancer. She was started on an aromatase inhibitor, letrozole, which she was on for about 9 years. In 2012, this was discontinued because of disease progression. The endocrine therapy was switched from an aromatase inhibitor to Faslodex, which she continued for about 2 years, and then that was discontinued because of disease progression. She was then started on navalbine by her primary oncologist, was on navalbine for about a year, and that was discontinued for disease progression. So she was seen in the medical oncology clinic for discussion of management options. Go to the next slide. We had obtained her molecular genotyping report based on Snapshot. So Snapshot is our institutional molecular genotyping platform which evaluates various genes for mutations. So for this particular patient, the pleural specimen was genotyped and revealed presence of a PIK3CA mutation, as you can see the first one, as well as an ESR1 mutation. So the interpretation was that this patient has a tumor which harbors both a PI3 kinase mutation and an ESR1 mutation. So we'll now review what's the significance of these mutations, particularly ESR1, and how that could potentially guide management of this patient. Next slide. So the clinical issues to consider when we are seeing a patient with breast cancer who has a genotyping report, I think can be divided into 4 questions, and this was covered by Dr. Park as well. The first question to consider in reviewing a molecular genotyping report is what's the specific frequency of that mutation in breast cancer. So if you're seeing a PI3 kinase mutation, is it a mutation that has been described before, or is it a mutation that we are seeing for the first time, has never been described before? So the first thing to consider is what's the specific frequency of that mutation in breast cancer. The second question to consider is what's the functional significance of that mutation. So if the tumor harbors that mutation, what happens to that tumor? What happens to that cell? What's the significance of that specific mutation? And these are important issues to consider before deciding to act on those mutations. The third question to consider after you figure out that this is a mutation that has been described before and potentially could be important is what are the potential strategies to target that mutation. So if you identify that this might be something that is important and actionable, can you actually target it, and what are the potential strategies to target that mutation? And I would also say that pathway, because sometimes you don't have direct inhibitors and you would potentially be targeting the pathway rather than that specific mutation. And an example would be KRAS mutation, for which we don't have direct inhibitors, but potentially we could target that pathway. And the fourth thing to consider is whether a clinical trial is available or whether you should consider off-label use, as Dr. Park mentioned, or whether you should still proceed with standard therapies. So these are the 4 issues to consider when faced with a molecular genotyping report and you're seeing a patient with breast cancer. Move to the next slide. So I'll use these 4 points to talk about ESR1 mutations. So this patient had an ESR1 mutation that was seen in the breast tissue. So the first question to consider is what's the frequency of ESR1 mutation in breast cancer? And this has an interesting story because the answer is it actually varies, and it actually depends on the specific specimen that you're analyzing. So if we go to the next slide. If we look at the original TCGA report that was published in 2012 in Nature, ESR1 mutations were not even mentioned in the TCGA breast report. So TCGA was the comprehensive molecular profiling of breast cancer. It described various mutations, various amplifications, and essentially was considered the molecular atlas of breast cancer. And in that report, ESR1 mutations were not even described. Go to the next slide. But a year later, a number of groups described the presence of ESR1 mutations that were seen in the metastatic specimens. So a key point to note is that the TCGA was analysis of more than 500 specimens that were all primary breast specimens. They did not analyze metastatic specimens, but when metastatic specimens were analyzed, it was found that up to 50% of metastatic breast tumors could harbor ESR1 mutations. So potentially either it's an acquired mutation that comes in response to endocrine therapies such as aromatase inhibitors, or it is a mutation that is very rare in primary tissue, but over time gets amplified as these, as potentially it could be a subclonal mutation, and over time that gets increased. We also looked at, next slide. We also looked at ESR1 mutations in circulating tumor cells, and we found a similar story, that you could see ESR1 mutations in patients with metastatic breast cancer by culturing their circulating tumor cells, but the ESR1 mutations were not present in the primary tissue, suggesting that this is something that is seen more in patients with metastatic breast cancer and potentially has a role in patients with metastatic breast cancer as opposed to sequencing primary breast cancer. So in our analysis, out of 6 patients, 3 of them had an ESR1 mutation. Next slide. And Dr. Park has also done work in this area looking at circulating tumor DNA, and they also found that 50% of patients who had metastatic disease, you could detect ESR1 mutations by digital PCR. But if you analyze the primary tissue, the ESR1 mutations were not seen. In this report, out of 12 patients, 3 did not have tissue that could be analyzed. But of the 9 patients, they were not able to detect ESR1 mutations. And Dr. Park could potentially comment on that later as we go into questions. In another trial, the Bolero-2 trial, which was a trial that randomized patients with ER-positive metastatic breast cancer to exemestane or exemestane versus everolimus, they reported the results of ESR1 mutations at San Antonio last year and reported that about 15% of patients had a specific ESR1 mutation, 538, and 7% of patients had a different ESR1 mutation, Y537. And overall, the prevalence was 28%. So about 1/3 of patients had an ESR1 mutations that could be detected by ctDNA analysis in patients with metastatic ER-positive breast cancer. So it's something that is present, is not that uncommon, and multiple groups have found the presence of ESR1 mutations in breast cancer, suggesting that it's probably it's a real phenomenon. So now that we know that it is something that is present, that has been described, the next question to consider is, what's the functional significance of the ESR1 mutation? So if the tumor has ESR1 mutation, what happens to that tumor? And essentially, the ESR1 mutation is a mutation that occurs in the ligand binding domain of the estrogen receptor. So it occurs in the spot where the estrogen binds to the estrogen receptor. And when you have a mutation in the ligand binding domain, the tumor becomes estrogen independent. So in general, the estrogen receptor has a closed conformation. When estrogen binds to the estrogen receptor, it forms an open conformation which leads to estrogen signaling. But when you have a mutation in the ligand binding domain, the switch is constantly on, if you will. So the tumor becomes estrogen independent. And you can imagine that if a tumor is estrogen independent, you can have the breast aromatase inhibitors, but they are not going to work because the tumor is estrogen independent or ligand independent. So when you have mutations in the ligand binding domain or ESR1 mutations, the tumor becomes estrogen independent, and potentially the drugs that are going to work would be drugs that target the estrogen receptor rather than the drugs that target estrogen. So potentially estrogen receptor blockers or degraders would work in tumors that have an ESR1 mutation. And this led to a renewed interest in developing ER degraders. So for this patient, we reviewed these issues. Then we came to the next 2 points, which was, how do we target the ESR1 mutation that is present in this tissue, and whether a clinical trial is available. Fortunately, we did have a clinical trial with a selective estrogen receptor degrader with a drug called GDC-810. So GDC-810 is a drug that binds to the estrogen receptor and essentially degrades the estrogen receptor. It's an oral drug. and simplistically could be considered as an oral fulvestrant. In preclinical models, it's much more potent as compared to fulvestrant. So as we can see, it binds to the estrogen receptor and then essentially degrades the estrogen receptor. So potentially it could be an option, particularly for tumors which harbor this ESR1 mutation. Next slide. So this is an example of a patient, not this patient, but another patient who had multiple sites of disease as assessed by FES PET scan. FES PET scan is a PET scan which looks for estrogen receptors. So you essentially get fluoro-labeled estrogen. The estrogen binds to the estrogen receptor, and then you can detect that with a PET scan. So the pre-treatment FES PET scan is shown on the left. The patient then received GDC810 and had a complete response based on the PET scan, suggesting that the drug can bind to the various estrogen targets. And clinically also, the patient did well. So for this individual patient, the patient did start GDC810, the selective estrogen receptor degrader, and as of last month is doing well on the clinical trial. So this patient has been on the clinical trial for about 9 months. Now, additional questions to consider, and this was mentioned by Dr. Park as well, is when you have multiple alterations, which one do you choose? Which one do you target? So this patient had both ESR1 mutations and PIK3CA mutations. Should you target ESR1, or should you target PIK3CA, or should you target both? Could you potentially target something that is downstream? So you have ESR1 mutations or PIK3CA mutations. If they all converge to one nodal point, should you actually target that nodal point as opposed to targeting the specific mutations? And should you actually look at the mutant allelic frequency to assess whether that mutation is clonal, meaning that it's present in all cells, versus subclonal, meaning that it's only present in a few cells? So these are some of these issues that we constantly struggle with when we see a patient with metastatic breast cancer who has a genotyping report. For example, the case that Dr. Park presented, the patient had a MEK amplification, so the MEK inhibitor, trametinib, was used, but the patient also had other amplifications, cyclin E amplification, MYC amplification, TP53 mutation. So should you target all of those? And even if you can target all of those, how would you target a tumor with 5 drugs? You run into these issues of combinations and adverse effects. So these are some of these issues that that we struggle with, and I just wanted to highlight that this is a complex decision, and that's why discussion in a tumor board is very important.
That's great. Thank you, Aditya. So I'd like to open the conversation to oral questions if you're on camera, or if you'd like to type a question in the chat box on the left-hand side of the screen just by typing it in there. We could convey the question to the speakers. Thank you. Maybe I can start. I wanted to ask, Ben, in your gateway tumor board, do you see patients or do you just see reports, or both?
We just see patients. Again, sometimes they'll be my patients or my colleagues' patients who are on the tumor board, so they'll know them, and we try to actually get the referring physician, if they're available, to present either via teleconference or in person at the meeting. We find that to be valuable in kind of helping us understand where the patient is at the kind of where they are in terms of their therapy and progression of their disease. And again, from our point of view, we've really only been discussing metastatic cases. We don't think that for the majority of cases right now that this has a role for early stage, potentially curable disease in the adjuvant setting. So we're really just doing this right now on patients with metastatic disease who have a biopsy and a report.
Yeah, sorry, Ben, why don't we take some questions from other people? Does anybody want to speak up? Maybe I'll ask you another question, Ben, just while we're waiting. Has anybody studied the literature as to the likelihood of patients responding to targeted therapies found in this manner overall in the world in general, like in all mutations, in all kinds of drugs? Is there a composite report on the efficacy of targeted therapies?
There are smaller studies. There hasn't been, to my knowledge, and Aditya, correct me if I'm wrong, big multi-institutional global studies, but usually single or maybe two institution studies which have different questions, one of which the early ones, do patients respond? And again, I think depending on which report you read and how you define clinical response versus clinical benefit, it can be a little bit all over the place. I think that that's another challenge. You're exactly right of how do we even define, you know, does this work? Does this lead to anything useful for patient care?
Yeah, I mean, I'm a little bit concerned just in general in clinical trials, not just targeted therapies, but of trialists being slightly ethically coercive of patients by holding out a fig leaf or a promissory note about a new treatment that actually has been shown very infrequently to work. How do you handle that, Aditya? How do you handle the ethics of offering clinical trials generally, or these particular group of agents? Do you have a minimum bar of? I know you've said FDA approved, of course, but for non-FDA approved agents, do you have a minimum bar of sort of efficacy to have been shown before you offer this kind of treatment off-label or something like that, and offer the patient and their family some hope?
No, it's a very challenging issue, because by enrolling in a clinical trial or by not using a standard drug, you're potentially depriving the patient of something that could work. So standard therapies do have some track record, and it's when you feel that the clinical trial or off-label use would be better than that standard therapy, that's when you would potentially consider that. So for the case that Dr. Park presented, the patient had progressed on multiple therapies. The patient had progressed on eribulin, the patient had progressed on Xeloda, and you know that, yes, maybe you can give a different chemotherapy agent like navalbine.
But you always go back to that again later.
You can always go back to that later, and also the likelihood of that working is low. So potentially at this time, the patient might be a candidate for a trial, might not be a candidate for trial down the road. Many of the trials also have restrictions on the number of prior lines of therapy that you receive. So I think it's a constant struggle, and as long as you're honest and upfront, I think you can make the best decision for your patient.
Ben, there are so few, usually mutations, rare mutations that are discovered are somewhat rare. Their frequency is not much, so there's not a big world experience. Has anybody ever tried to start correlating a mutation with a clinical observation, like the type of tumor or the type of patient that might house that mutation? Has anybody attempted that sort of correlation yet? What do you think, Aditya?
I'm sorry, what's the
my question, Ben, is that we are all clinicians, and we always are tempted to go back and correlate scientific findings with clinical presentations of either the patient or the tumor. Like, oh, this is common in African American women, or it's common in triple negative breast cancer, or something like that. Are these mutations frequent enough that the meta-analyses are starting to emerge that look at other characteristics that might be predictive of housing a particular mutation?
That's what you're saying. I actually think that's happening slowly, but again, generally speaking, especially with breast cancer, there's just not enough of a common mutation to really, or at least new ones. For example, we know PIK3CA mutations now are more associated with luminal types or ERPR positive types of breast cancers, whereas the other end, we know that the vast majority of triple negative breast cancer patients will have a P53 gene alteration. And so some of that is coming up, but as a case in point of somewhat what you're saying, there's a very rare type of breast cancer called secretory breast cancer. Some call it juvenile secretory breast carcinoma. That's a very different type of breast cancer, happens in younger patients, sometimes teenage patients, and that's really been characterized now by a specific type of translocation, a genetic anomaly that really now defines that type of breast cancer, and that's very akin to the Philadelphia chromosome and CML, or chronic myelogenous leukemia, where that's the initiating event. And now, to be a CML, you really have to have some sort of genetic alteration in that type of.
And if you decided to move country and move to Brazil, because we are doing a global tumor board here, or move back to India or whatever, what do you think the appropriate role is for either laboratory testing, clinical trials? Are the drug companies simply using global patients to create numbers for the FDA, or is there actually a more altruistic reason? What are the motivators for doctors abroad to participate in this type of research? Is the technology being transferred? I mean, are you willing, and is it easy for people to replicate your laboratory techniques where appropriate, and can you teach them to other scientists abroad? You know, one of the questions that people have asked me is, can we learn from your scientists how to do this so we can do it ourselves? What do you see the role of the developing world in this kind of endeavor, Aditya, if any?
I think it could potentially have a role if we talk about clinical significance and clinical utility in tumors which have a poor prognosis. So in tumors where patients will not do well with standard therapies, and there's clearly an unmet need to develop better therapies, I think this could potentially have a role. As opposed to tumors for which there is an extensive list of therapies that work very well, then I don't think so that we'll be able to make much of a difference for the amount of investment that goes in. So it's all about the delta, the difference that you can make.
Right.
Yeah, I would agree with that. I think that the other aspect of it is that sequencing is kind of like Moore's laws for computers, but even more so, where it keeps getting faster, better, and cheaper. And so I do envision a day where this could be done very cheaply, maybe even a portable kind of kit or something that could be sent out to company or to countries where, you know, the presence isn't quite visible right now. Yeah. But again, I think it's also going to behoove and fall upon us to really help educate what do these mean. I see a lot of this right now just in sitting on this tumor board, where we get reports and questions from community oncologists, let's say, that aren't necessarily going to understand the difference between a synonymous mutation, let's say, versus a non-synonymous. And so those are challenging, and we're trying to help out with it to the best of our abilities.
Can I just add that one of the arguments in favor for this type of research in the developing world is somebody has to do it to keep abreast with the science. So when the new version of the iPhone is made, somebody knows how to use the old one. Mm-hmm. Otherwise, it's impossible to adopt a new scientific, meaningful scientific endeavor if you haven't kept up to date. So a lot of these major centers, tertiary centers in Sao Paulo and Lima and other places, want to run this type of analysis themselves, so their scientists are ready to catch a meaningful wave of inexpensive, high-capacity testing, as Ben is alluding to. So I think that's an argument in favor of participation. But I'm a little bit less enthusiastic about many patients being enrolled on trials where the trials are very small and where the drug companies are really using the developing world as a recruitment tool and not as a scientific tool. You know, I'm a little bit leery of that.
I think one important thing would be that if information is collected, it should be collected on a systematic basis, because there are definitely ethnic variations. Look at the EGFR story. That's much more common in the Asian population. So I think if sequencing is done in other populations, you can actually see the ethnic variations and potentially develop drugs for that population.
Can I just, sorry, Ben and Aditya, just bear with me for adding a little piece of history. I was very intrigued by your fluorinated estradiol PET CT scan, and I wanted to go back to 1980 when the MRI machine was being developed for the first time in the United Kingdom. And at the Royal Marsden, the only MRI that was done in the beginning was on small animals like a mouse or a rat or something. So they had a kind of sleeve to put a small animal in. And we developed steroid molecules like estrogen, like the fluorinated estradiol, are very easy to fluorinate. You can very easily fluorinate a steroid molecule. So we developed fluorinated estradiol, and we used the sleeve that were designed for small animals to put over patients' skin nodules to see where the estrogen, and then we infused estrogen to see if fluorinated estrogen to see if it was still entering the tumor. So this is actually a very intriguing piece of history for me. The world's gone in a full cycle, and fluorinated PET estradiol screening is precisely what we were doing in 1980 in London. Yeah. So that's just an interesting piece of history.
We have a question from Susan.
Yeah, Susan, please go ahead.
So I typed it. I didn't know what was easier. But Aditya, have you seen ESR1 mutations in patients who have only been exposed to tamoxifen and not to an aromatase inhibitor? Or is this a unique clinical change with exposure to the AIs?
So it does appear that it does occur on exposure to AI, and from a biology perspective, that would make sense. If a tumor is being deprived of estrogen, and that's the way that therapies are working, it develops a mechanism by which it bypasses that step, becomes estrogen independent. Now, whether it's seen with tamoxifen or fulvestrant, I think the jury is still out. We don't know. As we gain more experience and as we have more of these ctDNA or CTC studies, I think we'll be able to address that question.
Susan, it's interesting that you mentioned that, because one of the only times these mutations that I'm aware of have been reported in TCGA, which is largely just primary tumors, have been in actually endometrial cancers. And for sure there are estrogen receptor mutations in breast cancer, but they're kind of all over the place. They're what we probably think are just incidental or passenger mutations. But these ligand binding mutations have actually been described in the endometrial cancers, a few of them in TCGA, and there's speculation that, well, maybe these were patients who, for whatever reason, were taking tamoxifen or something like that. So, as Aditya said, the jury's still out. I'm not aware of any studies that have documented this on purely tamoxifen alone, or at least published studies. And in fact, I think it's even rare to find patients who have been purely on just one therapy or an AI alone. We had one in our series, but again, because these patients tend to go on multiple endocrine therapies by the time we see them, it's difficult to know.
But I must say that in the spirit of the tumor acquiring a circumvention of a blockade of ER signaling, you would think that either tamoxifen or aromatase inhibitor would pressurize the tumor evolutionary-wise to find a circumvention pathway through a mutation of the binding site. So but I'd also like you to comment on the fact that one school of thought believes that everolimus, the mTOR inhibitors, are most effective in patients who are resistant to AIs, who've seen an AI before, not de novo patients. Is that a sort of acquired? Is ESR1 possibly an acquired mutation? That's what you're suggesting, a drug-acquired mutation, right?
I think so. I think this is either an acquired mutation that occurs on exposure, on prolonged exposure to AIs, or it's a mutation that is present in very small quantities, but is a mutation that confers advantage or resistance to AIs, so over time increases, and that's where you can pick it up.
So one of the things that Angela Brody showed with her animal model, and I tried to replicate clinically and had some cases accrued, but not enough to make the point, but I've reported case reports, is intermittent endocrine blockade to avoid. So as you know, the prostate guys give intermittent endocrine therapy rather than constant, and they show a better efficacy and a less toxicity, obviously. We tried the same thing with AIs, and there's the trial that the Soleil trial, I think it's called, the Australian trial, where AIs are given adjuvantly, intermittently. Do you think constant drug exposure in the laboratory, is that what induces this mutation? Would intermittent, because Angela's tumor-bearing animals suggested that intermittent therapy obviated the induction of these mutations to produce tumor progression. What do you think about that?
And potentially it could, and I'm very curious to know the result. I would be very curious to see the results of this 10-year of AI versus 5-year of AI. As that adjuvant trial is completed, when blood is collected at the end of 10 years, would we see a difference in the presence of ESR1 mutations or not? I think that would be an important
Well, there's going to be blood. There's going to be peripheral blood DNA and peripheral blood samples and plasma samples and tumor samples. Jim Ingle has spearheaded that for the MA17R trial. So this tissue is going to be available to all investigators, so that will be possible to look at, I think.
I think
the only problem is that the event rate goes down and down and down with time, so you've got very few cases versus controls, So it's more difficult statistics to prove a point as you get further out. But that is interesting, yeah. Ben, anybody else a question for Dr. Park or Dr. Bardia? There's one. Yeah, what's the question? We just want to have a look.
No question. How many?
I'm going to go with that one, teacher. Do you understand the question?
So the specific question is how to design a trial with too many options of mutations and stages of disease. And I think this is probably leads into a trial that is ongoing in the US, which is a match trial in which patients are randomized or to receive either standard of care or a specific targeted therapy based on the alteration. So if an alteration X is present, the patient would receive therapy Y. If A is present, the patient would receive therapy B, and so forth. And I think that trial would answer this question, whether if a specific mutation is present and you use a targeted therapy for that mutation as opposed to standard therapy, whether that would result in better outcomes.
I think just to add to that, part of the question is what you would also said, Aditya, is like, what if you have multiple mutations? And some of that we struggle with as well, as Aditya was referring to. Sometimes we use things like the evidence that this particular mutation may be an earlier driver mutation within that patient's tumor, so hopefully it would be present in all the daughter cells throughout all the metastatic lesions, or at least the vast majority, or what is the functional significance, or what is, in terms of the different drugs available for a patient with multiple mutations, which one has the highest likelihood of working given what the current literature states. So again, it's in flux. I think for the match trial there are algorithms for each tumor type as well as the mutations that one might find in the drugs available.
And potentially one could consider something that is nodal. I think the CDK4/6 inhibitor is a nice story in that angle, because CDK4/6 is downstream of multiple pathways, and so essentially is the nodal point, and you can have various alterations, but maybe all of them converge in that pathway, and if you use an inhibitor that targets that nodal point like CDK4/6 inhibitor, that could potentially work, and we've seen good success with CDK4/6 inhibitors in metastatic setting.
Well, I would like to maybe draw the session to a close if there are no other questions. And Ben, I know you've got to go to your Gateway meeting now, just a few minutes after 11. So I'd like to thank you very much, Ben, for a very informative presentation and discussion. And same with you, Aditya. That was really great. I think everybody benefited. If there are any follow-up questions or references or anything that people would like, we can pass them on to Ben and Aditya and get questions answered. But that was a very interesting tumor board and something quite different for what we usually do. You've both participated on our usual tumor boards, and you can see how important this presentation has been. So thank you both very much. Thanks a lot.
Thank you.
And thanks for attending, everybody. Thank you.
Bye.
Bye now. Thanks, Aditya. That was really